Imagine experiencing this agonizing, like really sharp pain during intimacy, right?
Hmm.
And you go to a medical professional looking for answers. They tell you, well, the solution is to tighten up tissues that have felt a bit loose lately.
Which, I mean, sounds logical on the surface to a lot of people.
Right, it sounds totally logical. So you follow that advice, you go through the treatments, maybe you even undergo a whole surgical procedure, only to wake up and discover that the treatment itself permanently trapped your pelvic nerves.
Making the original pain exponentially worse. It's just awful.
Exactly. And the most heartbreaking part of all this, the looseness and the deep pain had absolutely nothing to do with each other in the first place.
It is a really devastating scenario.
Yeah.
And it happens far too often, mostly because of a fundamental misunderstanding of pelvic anatomy.
Mm.
Like, people assume that surface-level structural shifts are the cause of these deep internal collisions.
Right. To put an image to this, think about a building showing as age. A hallway might feel draftier or, the floorboards have more give. But imagine walking down that drafty, wider hallway and suddenly, boom, you can't get to the end because you hit a locked, heavy iron door.
And you might instinctively think, well, the hallway is old and widened out, so that must be why I'm hitting a wall.
Yeah. But the draftiness of the corridor and the iron door blocking the exit are two entirely different architectural problems, right? Fixing the draft by adding weather stripping is never going to tear down that locked door.
No, it won't.
Yeah.
And trying to treat them as the same problem leads to those incredibly counterproductive and sometimes really harmful outcomes we just mentioned.
So welcome to this personalized deep dive. Today we are looking right at you, the learner. We are unpacking a highly misunderstood medical mystery today. We've got a massive stack of medical texts, clinical guidelines, and urogynecology articles right in front of us.
Lots of heavy reading today for sure.
Oh yeah, so much. And our mission is to explore a very specific question. If a woman feels like her vaginal tissues have become loose, which is a condition called vaginal laxity, could that somehow be the hidden cause of deep, sharp pain during intimacy?
And the short answer is no. But the long answer takes us on this incredible journey through the mechanics of the human body.
Let's start by defining our terms, beginning with that feeling of looseness. The medical texts refer to this as vaginal laxity. So what is actually happening to the tissue on a mechanical level here?
Well, vaginal laxity is fundamentally a loss of elasticity,
Right.
right? It's a loss of tissue tone and a degradation of the structural support in the vaginal walls. The sources point to two main culprits.
Okay, what are they?
The first is vaginal childbirth, which, as you can imagine, overstretches the pelvic floor muscles and the crucial ligaments that support the pelvic organs.
That makes total sense. And the second?
The second major factor is aging, specifically the hormonal shifts surrounding menopause.
I want to pause on the menopause aspect for a second because we always hear about the estrogen drop, right? But what does that drop actually do to the physical architecture of the tissue?
Oh, the microscopic chain reaction is fascinating. So in a healthy premenopausal environment, the superficial cells of the vaginal lining shed constantly. And when they shed, they release glycogen.
Which is like food for the good bacteria, right?
Exactly. It feeds the lactobacilli. But when estrogen levels plummet, that entire ecosystem changes. The mucosa, which is the lining itself, thins out significantly. And the fibroblasts, which are the specialized cells responsible for producing collagen, well, they basically go dormant.
And collagen is like the scaffolding holding everything up.
Yeah, it is the biological scaffolding. Without active fibroblasts, no new collagen is made. The existing collagen fibers begin to fuse together awkwardly, and the elastin fibers, the ones that provide that snapback quality, start to fragment and gore down.
So the scaffolding essentially melts away. And the physical reality of this for someone experiencing it usually involves a feeling of a widened opening. The medical texts call that a gaping introitus.
Right, gaping introitus.
There's a noticeable lack of physical friction, decreased natural lubrication because the tissue is thinning, and just an overall reduced sensation. The hallway has gotten wider, less firm, and significantly drier.
That is the perfect way to visualize laxity. Now, we have to contrast that with the pain. It is crucial to specify that we are not talking about a superficial stinging or burning right at the entrance.
Which would make logical sense if the tissue is dry and thin.
Right, exactly. Surface abrasion makes sense there. But we're specifically looking at deep dyspareunia.
Deep dyspareunia, which some of these papers refer to as collision dyspareunia. The name alone kind of makes you wince.
It really does. It describes a pain felt deep inside the pelvis, usually during deep penetration or pelvic thrusting.
And it's characterized as this sharp, aching, or throbbing pain that doesn't just happen in the moment, right? It can linger for minutes or even hours after intimacy stops.
Yeah, and the lingering nature of that ache tells us a lot about what structures are involved.
Mm.
It indicates deep tissue inflammation or severe muscle spasm rather than just a surface abrasion.
Here is where I have to play devil's advocate, though, going back to our architectural analogy.
Okay, lay it on me.
If the vagina is a hallway, and laxity means the hallway has widened out and lost its firmness, shouldn't it be much easier to avoid hitting things? Like, if there is literally more room, why is this deep collision pain happening? It feels paradoxical.
It is the exact paradox that trips up both patients and, frankly, some clinicians. To solve it, you have to look completely past the walls of the hallway and examine what is happening at the very end of it.
The locked doors?
Yes, the true culprits of deep dyspareunia have absolutely nothing to do with the tightness or looseness of the vaginal walls themselves. They are anatomical roadblocks.
So, to understand these roadblocks, we really need to look at how the body normally navigates this space. If you look at the classic Masters and Johnson research on human sexual response, which is cited in these clinical texts, they map out what the canal is actually supposed to do.
Right, because it isn't a static pipe. It
Yeah.
changes.
Yeah. The upper end of the vagina physically lengthens by about 3 to 4 centimeters during arousal, and it also expands laterally to a width of 6 centimeters or more.
And simultaneous to that lengthening and expanding, the uterus actually elevates.
Mhm.
It physically lifts up and out of the way, creating this sort of tenting effect at the top of the canal to make room for penetration.
It literally extends its own length in real time. I mean, that is an incredible piece of dynamic engineering.
It really is.
But that normal, pain-free expansion relies entirely on the surrounding organs being mobile and flexible, doesn't it? What happens when a condition like endometriosis enters the picture?
Endometriosis completely ruins that mobility. It occurs when tissue similar to the lining of the womb grows outside of the uterus. And a notoriously common spot for these endometrial implants to thrive is called the pouch of Douglas.
The pouch of Douglas. That sounds like a hidden room.
It basically is.
Yeah.
It's this small anatomical cul-de-sac tucked right behind the uterus, sitting snugly between the back of the upper vagina and the front wall of the rectum.
Wow, a literal hidden compartment in the pelvis.
Yeah, and normally the tissues in that cul-de-sac glide freely against one another. But endometriosis triggers chronic inflammation.
Which leads to scar tissue, I assume.
Exactly. Chronic inflammation leads to fibrosis and eventually thick, rigid scar tissue. This scar tissue acts like superglue. It can literally cement the front wall of the rectum to the back wall of the upper vagina.
Oh, wow. So let's walk through the mechanics of that during intimacy. A woman becomes aroused. Her body sends the signal to create that tenting effect you mentioned. The upper vagina instinctively tries to pull upward and lengthen those 3 to 4 centimeters, but it can't.
No, it can't, because it is violently tethered down. The glued, scarred tissue just refuses to yield.
So when deep penetration occurs, it's pushing against a wall that's literally cemented to the bowel.
Yes, it stretches and rips at diseased, inflamed tissue. The pain resulting from that traction is absolutely agonizing.
Think about what this means for you listening right now. If you or your partner are navigating this deep, sharp pain, trying to do Kegel exercises or using treatments to tighten the vaginal walls is, well, it's an exercise in futility.
It really is. Tightening a loose wall will not unglue a cemented pouch of Douglas. You're trying to fix a problem in a completely different zip code of the pelvis.
But endometriosis is just one of the locked doors we find in the research, right?
Right. The sources list an array of other structural abnormalities that cause deep dyspareunia, all operating as physical roadblocks. Consider a retroverted uterus.
Okay, what does a backward tipping uterus actually change about the internal mechanics?
It changes the angle of collision. Normally, the uterus tilts forward, resting over the bladder, so penetration glides safely past the cervix into the posterior fornix.
Out of the way.
Right. But when the uterus is retroverted, or tipped backward toward the spine, the body of the uterus falls directly into the pathway of the vaginal canal. Deep penetration ends up striking the uterus itself, which is highly sensitive and often tender.
So you are essentially ramming an organ that was supposed to be tucked out of the way. What about pelvic inflammatory disease, or PID?
PID involves widespread infection and inflammation of the reproductive organs. The tissues become swollen, boggy, and incredibly tender. When tissues are engorged with inflammation, any mechanical pressure applied to them is magnified into severe pain.
And uterine fibroids work differently, don't they?
Yeah, fibroids are benign tumors that grow in or on the uterus. Depending on their size and location, they can act as literal hardened boulders blocking the anatomical pathway.
We've focused entirely on reproductive organs so far, but the texts point out that the locked door isn't always reproductive. A gastrointestinal issue like irritable bowel syndrome, IBS, can be the culprit.
Yes, it can.
How does a bowel condition translate to deep vaginal pain?
It all comes down to visceral cross-sensitization. The pelvic cavities is tight quarters, and the organs share complex nerve pathways. The nerves innervating the bowel and the nerves innervating the vaginal canal travel along the exact same superhighways to the spinal cord.
Oh, I see where this is going.
Right. If the bowel is chronically inflamed or spasming due to IBS, those nerve signals can cross over. The brain gets confused about where the pain is originating, projecting the bowel pain into the vaginal canal.
The wiring gets crossed in the wall, so flipping a switch in the kitchen turns off the lights in the living room.
That is exactly the mechanism. And you see a similar crosstalk with interstitial cystitis, which is chronic inflammation of the bladder. The bladder sits directly on top of the anterior or front wall of the vagina.
So if the bladder lining is inflamed,
The upward pressure of deep penetration against that vaginal wall pushes directly into the inflamed bladder. It triggers severe, sharp pain.
so none of these conditions, fibroids, crossed nerve wiring, glued cul-de-sacs, inflamed bladders, none of them are caused or cured by changing the looseness of the vaginal opening.
Not a single one.
It is all about what hides behind the walls. Let me throw a massive curveball into this, though. What if a patient goes to the doctor, gets a thorough ultrasound, maybe even undergoes a diagnostic laparoscopy? The doctor reports there is absolutely no endometriosis,
Okay.
no fibroids, the bladder is healthy, the bowels are fine, the organs are completely pristine. Can a person have laxity from childbirth, so their superficial tissues are demonstrably loose, but still experience this deep, agonizing collision pain?
They absolutely can, and this introduces the pelvic floor paradox. To understand it, we must cleanly separate the vaginal mucosa, the superficial lining that gets thin and loose, from the deep pelvic floor muscles.
Those muscles form a complex layered hammock at the base of the pelvis, right, holding up the bladder, uterus, and bowels.
Yes. You can have a physiological state where the surface mucosa is highly lax and stretched out, but that deep muscle hammock underneath is suffering from severe hypertonicity.
Meaning they're too tight.
Exactly. The muscles are locked in a state of chronic spasm. This is really common in conditions like vaginismus or secondary pelvic floor dysfunction. The muscles involuntarily tighten and clench as a protective guard against pain or even just in anticipation of penetration.
So the tissue on top is loose, but the muscle beneath it is clenched tight as a fist, creating a physical barrier just as solid as a fibroid.
Yes. The clinical guidelines from the Greater Manchester Mental Health Trust use an outstanding analogy to explain how this muscle tension operates. They compare it to gripping a car's steering wheel tightly while driving.
Oh, I instantly relate to this. Like driving in the rain or heavy traffic, I white-knuckle the wheel without even realizing I'm doing it.
Right. The tension built subconsciously as a stress response. You only notice how hard you're gripping when someone points it out or, you hit a red light. You consciously draw your attention to your hands, take a deep breath, and let your arms drop.
You haven't lost control of the vehicle, but you've stopped exhausting your muscles.
Exactly. The pelvic floor operates the same way. It absorbs and holds on to tension from daily stress, from previous pelvic trauma, or simply from the ingrained fear that intimacy will hurt. It grips the steering wheel.
That mental image completely rewires how we should approach treatment. If your deep muscles are white-knuckling the steering wheel in a chronic spasm, doing standard Kegel exercises to tighten up the loose surface tissue is literally the worst possible intervention.
It is the equivalent of doing heavy bicep curls while your arm is already locked in a severe cramp. You're demanding contraction from a muscle desperately crying out for release.
So what's the therapeutic solution for hypertonic pelvic pain?
It is entirely focused on down training, letting go.
The physical therapy techniques outlined in these texts are deeply specific too. It is not just a vague command to try to relax. They utilize targeted diaphragmatic breathing.
Yes, breathing is key.
You lie down with your knees bent, placing your hands on your stomach, and as you inhale deeply, pulling the air down into your belly, your diaphragm physically pushes downward.
And that mechanical pressure of the diaphragm pushing down forces the pelvic floor hammock to gently stretch and drop. The key is consciously linking that physical drop with mental relaxation.
One source recommends visualizing a rosebud tightly closed, and as you draw that breath into your belly, you imagine the petals slowly widening and blooming. You actively visualize the muscle fibers lengthening and letting go.
And then you passively sigh the air out without tensing back up. It is all about retraining the brain to authorize the release of the muscle.
But for patients where breathing and visualization cannot break the chronic spasm, pelvic floor physical therapists employ manual interventions, right? The texts highlight feel massage.
Feel massage. This is an internal myofascial release technique. A specialized therapist internally locates the deep levator ani muscles inside the pelvis.
They find the hardened trigger points.
Exactly, the knots of spasm. And they apply steady rhythmic pressure to manually force the muscle to release trapped lactic acid and unclench.
We have established that vaginal laxity and deep dyspareunia are fundamentally unrelated in their origins. One is a loss of structural collagen, the other is a physical roadblock or a chronic muscle spasm.
Two different worlds.
But there is a scenario where these two issues crash into each other in a deeply unfortunate way. It is a critical warning for anyone navigating these symptoms.
We are talking about the intersection of treatment trauma.
Yes. If a person feels vaginal looseness or perhaps notices a mild pelvic organ prolapse where things are bulging slightly, they might seek out a surgical fix. They might look into a vaginoplasty or an anterior repair to reef up and tighten those loose vaginal walls.
But when we look at the clinical guidelines regarding these surgeries, a glaring red flag appears. The review from the UNC School of Medicine issues a stern warning about the collateral damage of pelvic surgery.
What happens?
Anytime a surgeon uses a scalpel to cut tissue, the body heals by creating scar tissue. If a surgeon cuts away mucosa to tighten the vaginal walls or inserts synthetic mesh to sling up a prolapsed bladder, the resulting rigid scar tissue can easily trap and compress delicate pelvic nerve bundles.
Furthermore, aggressively tightening the walls restricts that natural 3 to 4 centimeter lengthening process we discussed earlier.
Exactly. You have essentially artificially glued the tissue, mimicking the destructive mechanics of endometriosis. A patient might undergo surgery simply wanting to restore some tone and friction to their loose tissues, having never experienced a day of deep sexual pain in their life.
Right.
They heal from the surgery, attempt intimacy, and suddenly experience agonizing secondary deep dyspareunia. The pain was directly caused by the surgical scarring and nerve entrapment intended to fix the laxity.
It is the ultimate cruel irony. You try to fix the drafty hallway by building a brick wall right across the middle of it.
Precisely. Because of this risk, modern urogynecology has heavily pivoted away from using surgery as a first-line treatment for laxity, reserving it primarily for severe stage 4 prolapses where organs are protruding.
The focus now is on non-surgical regenerative alternatives that address laxity without a scalpel. The sources detail radiofrequency treatments like Morpheus 8V or Forma-V, as well as fractionated CO2 laser therapies.
Let's break down how these actually restore tightness without creating rigid scar tissue. These technologies rely on delivering controlled thermal energy precise heat deep into the submucosal layers of the vaginal tissue.
I picture it like aerating a lawn or doing a controlled forest burn. You deliberately cause micro-injuries to the old dormant tissue.
Yeah, the body registers that mild thermal trauma and triggers a localized healing cascade. It wakes up those dormant fibroblasts we talked about at the very beginning.
And the waking up of the fibroblasts triggers neocollagenesis?
Yes. The body synthesizes brand new, healthy collagen and elastin fibers from the inside out. It physically thickens the mucosa, restores the structural scaffolding, and improves the blood flow that drives natural lubrication.
It tightens the tissue organically without cutting away a single millimeter of the anatomy, thereby avoiding the massive nerve-trapping scars that lead to deep pain.
Exactly.
Let's synthesize everything we've uncovered. If there is a single defining takeaway from our dive into these medical texts, it is this. Vaginal laxity, that superficial feeling of looseness, airflow, and loss of friction, and deep dyspareunia, the sharp, lingering collision pain deep inside the pelvis, require entirely different roadmaps for healing.
Entirely different.
Laxity is a degradation of scaffolding and collagen. Deep pain means you are hitting a roadblock, whether that is glued tissue from endometriosis, an inflamed bladder, a misplaced uterus, or deep pelvic muscles white-knuckling the steering wheel.
But, our understanding of that pain changes radically when we look at what happens when those roadblocks remain in place for too long. If we connect the physical trauma of chronic inflammation or trapped nerves to the broader field of neurophysiology, we encounter a phenomenon called central sensitization.
Walk us through what happens to the nerve pathways when this pain becomes chronic.
Deep within our nervous system, we have specific nerve pathways called C fibers. Under normal circumstances in a healthy pelvis, these C fibers are silent.
Silent.
Right? They do not transmit pain signals during standard daily activities, normal digestion, or gentle touch. However, if the pelvis is subjected to repeated ongoing trauma years of severe muscle spasms, chronic inflammation from untreated endometriosis, or nerve compression from a surgical complication, those silent C fibers are jolted awake,
The alarm system gets switched on.
and it refuses to switch off. The nervous system fundamentally rewires itself to become hypervigilant. It begins to perceive normal, non-threatening stimuli like the natural expansion of the vaginal canal or even light touch as catastrophic damage.
Wow.
The brain receives a screaming signal of agonizing pain, even if the original endometriosis has been excised or the muscle spasm has been massaged away. The physical hardware of the pelvis might be completely healed, but the neurological software has developed a profound glitch.
Central sensitization means the nervous system has literally learned to feel pain in the absence of injury, which leaves us with a formidable question to ponder. If your nervous system can learn to manufacture agonizing pain to protect you, does true recovery from chronic deep dyspareunia require retraining your brain's perception of safety, just as much as healing your physical body?